At Jade Wellness Center, group therapy isn't an optional add on. It's the backbone of how we treat substance use and mental health together. We're a family owned, state licensed center, and part of what makes us different from more corporately run programs is our commitment to seeing the whole person. That means every group we run is co occurring capable. We recognize that depression, anxiety, trauma, grief, and other mental health conditions don't exist apart from substance use. They exist alongside it, often feeding into the same cycle. We see groups as a social microcosm, where the dynamics of daily life, conflict, trust, avoidance, intimacy, and shame, play out in real time. When our clients walk into group, they aren't just sitting in a circle. They're practicing what recovery feels like in the real world. They test honesty, accountability, and vulnerability in a safe space with feedback from peers and clinicians who understand both substance use and mental health recovery. We often say addiction is a disorder of disconnection. In group, that disconnection begins to heal. Clients see themselves reflected in others, borrow hope when theirs runs thin, and learn how to show up in relationships without substances in the way. Harm reduction fits here too. Not everyone enters group with the same goals. Some want abstinence, some want to reduce use, and some want to stay safe while figuring it out. At Jade, groups create a place where all of these goals can be spoken aloud, respected, and held with care. Different levels of care like PHP, IOP, and OP shape how we use groups, but the heartbeat is the same. ASAM reminds us that placement isn't about filling chairs or billing. It's about matching the intensity of care to dimensional needs like withdrawal risk, psychiatric stability, readiness to change, and recovery environment. And motivational interviewing also reminds us that ambivalence, resistance, and reoccurrence of use are not failures, but normal parts of change. In group, clients can see that truth reflected, supported, and worked through without shame. At Jade Wellness Center, the why of group therapy comes down to this. Groups are where people find connection, accountability, and belonging. They provide a living practice ground for recovery that integrates both substance use and mental health care. And because life is messy, groups meet people where they actually are, not where a textbook says they should be. Before we dive in, let's take a moment to look at where we're headed today. Group therapy in addiction counseling is rich, layered, and sometimes messy. At Jade Wellness Center, our goal is to give you not only the frameworks, but also the real world tools to navigate that messiness, tools that you can use in group tomorrow. So here's our roadmap. We'll start by looking at different group modalities and structures, psychoeducational, process, support, vocational, and how open and closed groups function, including hybrid and telehealth options. We'll also look at the role of mutual aid groups like AA, Smart Recovery, and Recovery Dharma, and how to introduce clients to them in a client-centered way. Next, we'll walk through the stages of group development, from forming to storming to adjourning, and discuss how these stages show up in addiction treatment. We'll add a co-occurring lens, how anxiety, depression, trauma, or other mood disorders often surface in each stage. And from there, we'll talk about how we measure success in groups, not just attendance, but engagement, peer feedback, movement across the stages of change, and ASAM dimension shifts. At Jade, this means documenting both substance use and mental health progress as co-occurring expectations. We'll also explore therapeutic factors unique to groups, drawing on Yalom's work and connecting it to real-world substance use recovery. And then we'll shift to the counselor's role, setting norms, managing storming and criticism, balancing empathy with authority, holding boundaries with loving accountability, and practicing trauma-informed inclusive leadership. We'll spend time on the realities of practice, ASAM criteria and placement, harm reduction and mixed motivation groups, and extreme parameters where discharge or referral may be necessary. We'll connect those directly to staff conversations we've been having around IOP versus OP, behavioral contracts, and how to navigate some resistance without enabling. We'll also highlight some specific issues unique to addictions groups, trust and confidentiality in small communities, relapse or reoccurrence of use, ambivalence and denial, and diversity of stories and identities. And finally, we'll close with counselor self-care. We'll talk about countertransference, supervision, practical decompression strategies, and I'll introduce the practice of noticing glimmers, which are just small moments of safety or hope that sustain us in this work. You'll be invited to identify a glimmer for today and one to carry into this week. So that's our agenda. Think of this lecture as a toolkit. You'll leave with frameworks, examples, and language that you can take into your groups at Jade, blending the art and science of group counseling. So starting with types of groups. For us, groups are never just topics. They are intentional spaces where people practice safer connection and learn to navigate both substance use and mental health challenges. Every group must hold our co-occurring lens, skills for managing cravings and skills for managing anxiety, trauma, depression, and grief. Across our programs, you'll see different types of group, like educational or psychoeducational, which is just building knowledge and skills about triggers, cravings, refusal skills, emotional regulation, sleep hygiene, grounding techniques, assertive communication. These are structured, goal oriented, and adaptable across all levels of care. Looking at a social type of group, this is practicing pro social behaviors, giving and receiving feedback, repairing conflict, learning to trust others without substances. These are corrective attachment experiences for people who may have never had them. And then we also use a personal or process type of group where we explore family roles, thought patterns, trauma responses, and attachment needs. These groups slow down, focus on what's alive in the room, and help clients experiment with new ways of relating. And no matter the type, the through line at Jade is interpersonal effectiveness, communication, and boundaries, the social muscles that sustain recovery and support mental health stability. At Jade, we run both open and closed groups depending on the level of care and clinical goal. Open groups are the workhorses of IOP, PHP, OP, and admissions are rolling, but members may be in very different stages of change. They can look a little chaotic, but that's also a strength. Somebody in maintenance can model for somebody in contemplation, creating peer mentorship and real life hope. Open groups also make individualized length of stay possible, which is far more client centered than forcing everyone into a rigid timeline or curriculum. Closed groups are typically theme based, like trauma skills or women's recovery or reentry after incarceration, MAT support, tobacco cessation. The predictability and fixed membership build cohesion, depth, and progressive skills session by session. So, how do we decide? If the program must absorb frequent admissions like IOP and OP, open groups ensure access and flexibility. If the goal is targeted skill building or identity based safety, closed groups allow for depth and protection. And recovery at J doesn't end when group is over. We connect clients to mutual aid communities early because long term recovery depends on belonging outside of our walls. We introduce a range of options from 12 step to smart recovery to recovery dharma. There's celebrate recovery, moderation management, women for sobriety, life ring, and so many more options. Choice matters. Clients should not feel pushed into one model. 12-step programs often resonate with those in action or maintenance. They provide structure, accountability, and a powerful culture of service. Smart recovery and similar groups resonate with those in contemplation or preparation. They emphasize CBT and social learning tools, coping with urges, emotion regulation, and balancing life domains. At Jade, introducing mutual aid is not an aftercare checkbox. It's how we build connection density during treatment. And just a practical tip, every discharge plan should include at least 2 mutual aid options. Encourage clients to try each twice before deciding. Choice builds buy-in and honors culture, goals, and preferences. And the fourth type of group that I want to talk about today is telehealth groups and hybrid groups. Since COVID, group work has expanded into more formats than just in person. And at Jade, we learned that while a virtual room doesn't feel like sitting shoulder to shoulder, the same fundamentals still apply: safety, structure, confidentiality, and presence. Some clients feel safer opening up online, others struggle with focus or technology barriers. A good facilitator will name these dynamics openly and co create group agreements. We want to take into special consideration privacy, multitasking, and respectful engagement in the group. Now, hybrid groups are when there are people in the room in person. I like to call them roomies, and then also people online. I like to call them Zoomies. And they're going to require a little extra intention. If not managed, these two groups can split into two parallel groups. So to bridge it, we want to rotate attention equally between cameras in the room and use maybe a roomy zoomy buddy for connection, alternate check-ins between virtual and in-person voices, and you can even use shared tools like Google Docs, whiteboards, or breakout rooms to keep the group culture unified. Done well, hybrid groups expand access while preserving the therapeutic power of connection. At Jade, this means a client working night shifts, a mom with childcare barriers, or someone with transportation struggles doesn't lose the chance to engage in treatment. When we talk about group development, you'll notice that different theorists use different language. Gerald Corey describes 4 stages: orientation, transition, working, and termination, while Bruce Tuckman adds a little bit more nuance with 5 separate stages. And I think I like these ones the best because they rhyme: forming, storming, norming, performing, and adjourning. Both models are useful and both remind us of an essential truth. Groups are living systems. They don't stay still, they shift, they move, they develop just like individuals inside of them. So the first stage that we're going to talk about is forming, and that's going to be Tuckman's forming and Corey's orientation. So at the very beginning, members are finding their place. They're figuring out, what is this group about? Who are these people? Do I even belong here? Can I trust anyone, including you? You might hear things like, how long do I have to be here? Is this going to be anything like AA? Or are you in recovery too? What's happening in the room is members are going to be cautious, polite, maybe testing some boundaries, and they're going to look to the leader for structure and safety. Your role is to set the tone, introduce group norms like confidentiality, respect, and attendance, and model openness without oversharing. Normalize that it's okay to feel unsure, and begin to shape the culture. Remind them that it's their group, that you can be there to guide, but what they do together is going to come from them. And the next phase is Tuckman's storming and Corey's transition. And this is where things really get real. Conflict arises, resistance shows up, people may challenge each other or you. And in addictions groups, this stage can be really loud, messy, and full of ambivalence. From a stages of change perspective, storming is often fueled by pre-contemplation and contemplation. Clients who aren't yet ready to give up the positives that they associate with use. Their resistance is part of the work and not an obstacle to it. And you might hear things like, this is a waste of time. She's always talking about relapse. Why should I even listen to her? Or you don't get it. I'm not like them. What you might notice happening in the room is old family dynamics reemerging, like sibling rivalries or parent-child projections or even scapegoating. Members are going to test boundaries. They'll show up late, crosstalk, side conversation, and there's going to be ambivalence surfacing as sarcasm, withdrawal, or even direct confrontation. From a stages of change perspective, this is where pre-contemplation and contemplation voices push the hardest. Clients may defend their use, minimize their problems, or project frustration onto the counselor or peers. Your role in this stage is to reframe resistance as ambivalence. Discord isn't failure, it's information. Ambivalence signals movement, not stagnation. You're going to reflect what you hear without escalating. So it sounds like you're not sure this group can help you. Thank you for saying that out loud. Who else has felt that way? Invite storming as legitimate. Conflict shows members are investing enough to risk being real. And remember, treat the group as the client. Instead of chasing each individual, hold up a mirror to the group as a whole. Say something like, hey, I noticed that we're splitting into sides here. What do you think that's about? And most importantly, hold safety. This is how we build enough connection for anything else to happen. So for a second, just think about the forces that your clients face. Criminalization, racism, poverty, family pressure, health inequities, trauma. When somebody has learned that authority equals danger, our first task is to be predictably safe. That means consistency, transparency, and showing members that their pushback will not break the group or drive you away. When you can hold storming this way, the group becomes a place where clients not only face their ambivalence, but also practice new ways of handling conflict, authority, and vulnerability. These are skills that they're going to need long after treatment ends. And the next stage is Tuckman's norming and Corey's working stage. Once the group survives storming, norms emerge. Members begin to trust, listen, and collaborate, and the group feels safer and more predictable. You might hear them say things like, we don't interrupt each other here, or remember last week? You said something that really helped me. You might even hear them saying, I used what we talked about and it actually worked. What you'll notice happening in the room is cohesion building, members enforcing norms themselves, and feedback becomes more honest but still caring. You're also going to see the group identity strengthening. Now, clients with anxiety may begin to risk vulnerability when they see safety reinforced. Depressed clients may gain energy from feedback, starting to recognize their own contributions, and those with trauma histories may experiment with trust and repair when they feel misattuned. Personality-related dynamics may soften as clients internalize healthier group norms. Your role as a counselor here is to step back a bit. Let members hold each other accountable, highlight therapeutic factors like hope, universality, and altruism, and continue to keep the focus on the group as a client. You might say things like, what's working for us right now as a group that helps us move forward? The next stage is Tuckman's performing and Corey's deep working. So at this stage, the group is clicking. Members are vulnerable, accountable, and engaged in real change. They test new boundaries in the group and carry them into their lives. You might hear them say things like, I realized I've been lying to myself about my drinking. Thanks for calling me out on it. Or, can we practice how I'm going to tell my boss I need some time off to go to meetings? You might even hear them say, this group is the first place I felt safe in years. What's happening in the room is group members trust each other and also challenge each other. Members practice skills together, role plays, feedback, problem solving, and relapse prevention feels alive and relevant. Your role as a counselor is to guide without dominating. Offer structure, but allow the group to take risks, experiment, and support each other. And bring the focus back to the group as a living system. What are we learning together about how we change? And the final stage here is Corey's termination and Tuckman's adjourning. Endings are emotional in addiction groups. Endings are emotional in any group. Termination can feel like loss, and loss is a major relapse trigger. You might hear them say, I don't want to leave. What if I relapse? Or I don't think I'm ready yet. Or this group saved my life. I'm scared of what's next. What you'll notice happening in the room is fear of losing connection. Relapse risk increases as the safety net loosens, and members may regress or pick fights as a way of distancing themselves before leaving. Your role is to name the ending openly, remind them that you've been working towards this moment, and encourage them to figure out a way to say goodbye. And this is an opportunity to establish some sort of tradition in your group about goodbyes and endings. How do you say goodbye to a member who's completed successfully? Is it a pizza party or a coin out ceremony or donuts or a potluck? The world's your oyster here. You can integrate relapse prevention in aftercare planning. You can model healthy closure, practice gratitude, affirm progress, encourage ongoing peer support. You could invite reflection. What did this group give you that you'll carry forward? And remember, it's not just termination for the group member who's successfully completing and leaving. It's also termination for all the other group members who aren't going to see this person anymore. So you might also want to ask them, what did you get out of knowing this person? And for co-occurring clients, reinforce mental health supports alongside recovery supports during this transition phase. You're going to want to make sure that they're set up with therapy, psychiatry, coping groups, or crisis plans. And I just want to talk a little bit about a note on beginnings and middles and endings. Different clients are going to struggle with different parts of this arc, and it's worth slowing down to notice how much weight each one carries. Beginnings can feel overwhelming. Walking into a group for the first time means facing uncertainty, new relationships, and the vulnerability of being seen. For some clients, this recalls the anxiety of first days, new schools, new jobs, or even early family experiences of not knowing whether they belonged or not. In a group beginning, you may see hesitancy, silence, or defensiveness. Clients might test you with questions like, are you in recovery too? Or mask discomfort with humor. Beginning is about making contact, deciding if it feels safe enough to show up authentically, and our task is to make the invitation clear, to normalize the anxiety of starting, and to model that it's okay to ease into connection at your own pace. Middles are where the work gets messy. This is the storming stage where resistance, conflict, or fear of intimacy comes to the surface. Clients might clash with each other, withdraw, or project family dynamics onto the group. Some discover that staying present with frustration or disagreement is harder than they expected. The middle is where unfinished business often shows up, those old relational patterns that repeat themselves in the here and now. A client who always retreats when challenged might suddenly go silent for weeks. Another who fears abandonment may monopolize airtime, pulling attention back to themselves. And rather than seeing these as problems to be solved, we can hold them as material to be explored. What's it like to sit with this tension instead of moving away from it? The middle is where endurance and tolerance of discomfort grow and where intimacy becomes possible. And finally, the endings. They're equally important and just as difficult. Closure stirs up loss, abandonment, and the ache of unfinished relationships. A client may relapse or disengage right at the point of graduation, not because they haven't learned anything, but because endings reopen old wounds. Others may cling, insisting that they aren't ready to leave, even when their progress shows otherwise. Endings can be moments of assimilation and integration, taking what's been learned and carrying it forward. But they're also moments of letting go, and that can be deeply uncomfortable. As group leaders, we hold endings gently and transparently, honoring both the grief and the pride that comes with moving along. And that's why we treat the beginnings, middles, and endings with equal care. Each is both a clinical moment and a practice run for life outside the group. For some, learning to enter fully is the growth edge. For others, it's staying through the turbulence of the middle. And for many, the hardest and most healing work is learning how to say goodbye without relapse or retreat. And I know all of that is all well and good, but you might be asking, but how do I know if I'm actually doing well? So I want to talk a little bit about metrics for success in groups. When we talk about evaluating group therapy, the temptation is to measure success in the simplest way possible. Attendance. Did the client show up or not? And while attendance is certainly important, it's only a starting point. Just being in the room doesn't mean somebody's engaged. It doesn't mean they're connected or practicing recovery. A fuller picture of engagement includes parameters like participation, disclosure, giving and receiving peer feedback, and role-taking within the group. Participation might look like a client showing their weekly struggles, but disclosure is going deeper, being willing to show vulnerability. Feedback is when clients not only speak, but also listen, offering reflections or challenges to one another. Role taking is when clients step up into leadership, welcoming new members, reinforcing norms, or modeling coping strategies. So, how do we track something as complex as group dynamics? One helpful tool is the sociogram. And a sociogram is just a fancy word for a visual map of who's talking to whom in the group. Imagine a classroom where the teacher does 90% of the talking. On a sociogram, it looks like a starburst. Every line goes from the teacher to the students and then back again. Now compare that to a healthy process group, where ideally everybody talks to everyone else and the lines crisscross in all directions. The counselor still has a presence, but instead of being the hub of the wheel, they're part of a web where the members are connected to one another. Tracking this visually can help us see whether the group is becoming a community or if it's still orbiting around the facilitator. Success also looks like movement across the stages of change. For example, a client in pre-contemplation who begins expressing ambivalence, that shift is just as much a success as somebody in maintenance demonstrating relapse prevention skills. And from a motivational interviewing perspective, success isn't a dramatic change all at once. It's about planting seeds, moments where clients can test out a perspective or voice even a small maybe. And it's about practicing well, rehearsing skills, experimenting with new behaviors, and building persistence even when ambivalence remains. These are the markers of progress that might not show up on a checklist, but they really do matter. And another way to think about metrics is relational outcomes. We're going to talk about it in a bit, but Yalom identified 11 therapeutic factors in group therapy. And some of the most healing elements in groups aren't skills or information, but experiences of hope, universality, and connection. Hope is sparked when a member sees someone a few steps ahead in recovery and thinks, well, if they can do it, maybe I can too. Universality is the moment when the client realizes that they're not alone in their shame, their relapse, or their grief. And social connectedness is the gradual weaving of relationships that can hold someone up when treatment ends. So when we ask, is this group working? The answer goes far beyond counting bodies and chairs. It's about the depth of engagement, the quality of relationships, and whether the group is practicing recovery together. So I want you just to pause here and take a moment to think about how you define success in the groups that you're leading. What metric feels meaningful to you? And is it something that you can measure, like attendance, participation, or sociograms of member-to-member interactions? Or maybe it's something more relational, like noticing a rise in hope, pure accountability, or the willingness to be vulnerable. How would you track or document that growth over time? So I want to talk about those 11 therapeutic factors that Irvin Yalom identified. And I think that they really help explain why groups can be so effective. They're not abstract theories, but they are in the lived moments that make group counseling transformative. So we're just going to talk about each one and give a thought about how they're showing up uniquely in the groups that you are running. The first is installation of hope. Hope is contagious. When clients see peers making progress, staying sober another week, reconnecting with family, getting a job, they begin to believe that change is possible for themselves. This is especially meaningful for clients in the contemplation stage who might not yet believe recovery is within reach. An example of this would be a new group member saying, I don't think that I can ever stay clean. And a peer responds, well, I used to feel the same way, but I'm 60 days in now and it's getting easier. The second is universality. Clients often arrived convinced that their struggles are unique. In recovery, this shows up as chronic uniqueness, the belief that I'm not like them, so treatment won't work for me. Universality dismantles shame by showing that others have faced the same cravings, guilt, or relapses. It also helps pre-contemplative members begin to see that change talk applies to them too. An example here would be a client sharing, I drank after my mom yelled at me. And another group member replying, I've done that too. Stress at home is one of my biggest triggers. The third is imparting information. Groups provide education and skills about cravings, relapse prevention, or coping strategies. But members also teach one another. For clients in preparation or action stages, this is often the nudge that turns ideas into practice. An example would be a client explaining how they're using grounding techniques to manage cravings, the facilitator reinforcing it, and then others trying it for themselves. The fourth one is altruism. This is helping others in the group boost self-worth and shifts the focus from shame to contribution. Even clients early in change can feel empowered by offering encouragement, while those further along model persistence. An example here would be a client who relapsed last week, encouraging a newcomer not to give up. That act of encouragement helps both people feel stronger. The fifth is corrective recapitulation of the family group. And I know that's a really big word, but really all it means is that groups echo family dynamics. Roles like the caretaker, the rebel, the quiet one. This can be uncomfortable, but it can also be a chance to heal. For many, this is where ambivalence in the contemplation stage gets activated. They recognize old patterns but aren't sure how to step out of them. An example here would be a client who always felt dismissed by their parents, sharing in the group, and the group listening to them with care. That moment provides a corrective emotional experience for that client. The sixth is development of socializing techniques. Many clients enter recovery with strained relationships, poor boundaries, or limited social skills. Group provides a real time practice. For those in action, this practice is essential. And for those in maintenance, it's going to be reinforcement. An example here would be a client learning how to say, I felt hurt when you interrupted me, instead of lashing out or shutting down. The seventh is called imitative behavior. Clients often model themselves after peers or the counselor. They try new ways of speaking, listening, or regulating emotions by copying what they see. For people in contemplation, this may be their first trial step towards action. An example of this would be a client begins reflecting back on another story, mirroring the counselor's use of active listening. The eighth is interpersonal learning. Groups are laboratories for relationships. Members get feedback they might not hear elsewhere and can experiment with new ways of connecting. These experiments often mark the shift from preparation to action. A client who tends to dominate conversations hears from peers, when you talk over, it makes it hard to share. And then they're going to use that feedback to create change in how they engage in the group. The ninth is group cohesiveness. This is the sense of belonging, feeling part of something larger. Cohesion is especially powerful in addiction work where isolation often drives substance use. It can provide an anchor for clients moving from action to maintenance, helping them stay consistent. An example here would be members rallying around somebody who admits relapse and saying, we're glad you came back. Let's talk about what happened. 10 is catharsis. And that means expressing emotions openly can be relieving and healing. Crying, venting anger, or sharing grief are all experiences of catharsis. And in addiction groups, this must be balanced so it doesn't overwhelm the process. Catharsis often shows up when clients in contemplation finally voice what they're holding back. An example here would be a client breaking down while describing the loss of custody of their child. The group listens and validates, making space for release without judgment. And the final and 11th factor is existential factors. Groups allow clients to confront big picture issues: mortality, freedom, isolation, and meaning. Addiction often raises these questions starkly. Clients in maintenance may find existential reflection especially important as they build a life beyond stopping use. An example here would be a group member saying, I don't know who I am without drinking. And the group holds that tension and explores meaning in recovery. Now, in addiction counseling, these therapeutic factors often show up in unique ways. The first being chronic uniqueness. So universality directly counters the I'm different narrative and can help contemplators begin to see themselves in others. There's also relapse disclosure. Cohesion, hope, and altruism shape how groups respond when someone admits relapse, ideally with support rather than shame. It also reframes relapse as part of the change cycle, not the end of it. And then there's that corrective emotional experience that I was talking about. Family reenactments can be intense in addiction groups, but they also create powerful opportunities for repair, moments that may move somebody from contemplation into preparation. And together, these factors remind us that the power of groups is not just in information delivery, but in the living, breathing interactions that help people move through the stages of change and practice recovery in real time. Being a group leader in addiction counseling is a little like being the conductor of an orchestra. You're not playing every instrument. In fact, if you try to play them all, the music will fall apart. Your task is to bring the pieces together, to help each voice find its place, to notice when one section is overpowering the others, and to keep the whole group moving in rhythm. At Jade Wellness Center, the orchestra always includes more than just substance use. Many of our clients bring co-occurring depression, anxiety, PTSD, or bipolar disorder into the room alongside their recovery goals. As group leaders, we are listening not only for cravings and relapse prevention themes, but also for panic creeping into the edges of disclosure, for hopelessness coloring the way that a member talks about their future, or for trauma responses that show up as silence or withdrawal. Our job is to hear the whole piece being played, even when it's dissonant, and to make sure clients feel both seen and safe in that mix. Your tasks include assessing group needs, what's really showing up in the room right now, and building culture. Early on, this means establishing and reinforcing norms: confidentiality, respect, showing up on time, allowing everyone a chance to speak. And at Jade, it also means naming from the start of the group that the group is a co-occurring capable space. We don't separate substance use from mental health. We invite members to bring both into the circle. Over time, it's less about telling and more about inviting the group to hold itself accountable. What agreements do we need to revisit to feel safe here? Your skills are the subtle tools that keep the group in tune. Flexibility and adaptability are essential. No matter how much you prepare, the group has a way of presenting something new. Reading the meta story means stepping back and noticing the bigger picture. Maybe the content is about relapse prevention, but the process seems to be about members competing for approval. Or maybe the content is about cravings, but the process is really about managing underlying depression or grief. Linking is when you connect one person's story to another's. So it can sound like, I hear something in what Joe just said might resonate with you, Maria. Blocking is when you interrupt behaviors that harm the group, like side conversations, repeated interruptions, sarcasm that silences others. Healthy confrontation means addressing these issues directly, but with empathy. When you cut him off, it seemed to shut him down. Can we pause and hear him out? Summarizing pulls the threads together so that the group doesn't get lost in tangents. And another important skill is knowing when to magnify some voices and when to minimize others. In any group, some members will naturally dominate while others hang back. If we let that dynamic run unchecked, the group's music gets distorted. Sometimes you need to amplify the quieter voices so that they feel heard and valued. Other times, you need to gently turn down the volume on the dominant members. This balancing act keeps the group democratic, where everyone has the chance to contribute to the collective work. At Jade, this also means noticing when a dominant voice may be driven by untreated mania or when a quiet voice is actually avoidance rooted in trauma. These aren't just personalities, they're clinical data tied to ASAM dimensions that guide our interventions. And special considerations are unique to addiction work. Here, culture matters. Groups must feel trauma-informed, safe, and trustworthy. Confidentiality must be emphasized constantly, not just a rule, but a living practice. What's said here stays here. Boundaries protect both clients and counselors, being clear about dual relationships and not letting familiarity blur professional lines. And trust is fragile. Once broken, it can take the whole group down. At Jade, this is why we practice loving accountability. Clients are reminded that honesty and boundaries keep everyone safe, and staff model the same standard. Practicalities also shape the group. Size matters. 12 or fewer participants allows everyone to participate without getting lost in the crowd. Duration and frequency depend on level of care. PHP groups may meet 4 or more hours a day, while outpatient groups may be just an hour or two each week. Preparation is key. You need a plan, but you can't cling to it. The art of group leadership is showing up prepared and willing to toss out your agenda when the group's needs call for something different. At Jade, this often means shifting from a worksheet on refusal skills to a grounding exercise when a client's panic attack derails the session. Both are treatment, both count towards recovery. And back to our metaphor. As the conductor, your job isn't to force every instrument to play the same note. It's to help them find harmony. Sometimes that means quieting the brass so that the strings can be heard. Sometimes it means letting percussion take over for a bit of energy. And sometimes it's about holding silence long enough for the music to breathe. In the same way, leading a group means balancing structure with responsiveness, magnifying some voices while minimizing others, and trusting that with guidance, the group can make music together that no individual could play alone. So when we think about group therapy and addiction treatment, it helps to start with the ideal world, the way that ASAM criteria describe how levels of care should function. In a perfect world, intensive outpatient or IOP groups would be filled with clients who present with dimensional drivers that warrant structure, high-frequency services. These might include unstable recovery environments like Dimension 6, ongoing cravings or substance use risk like Dimension 5, or co-occurring psychiatric symptoms in Dimension 3 that require close clinical support. In these settings, we expect most clients to be in the preparation or action stages of change, motivated, practicing coping skills, and experimenting with new behaviors. Outpatient or OP groups, by contrast, are designed for people with fewer acute needs. These clients may show greater stability in external supports like Dimension 6, and reduced acute withdrawal or biomedical conditions like Dimensions 1 and 2. Ideally, they're practicing ongoing recovery management skills, focusing on maintenance, reoccurrence prevention, strengthening networks, and building a sustainable lifestyle. But that's the textbook version. In reality, it rarely looks that clean. We often see IOP clients still in pre-contemplation or contemplation. They may be here because of a probation officer, a family member, or an employer. Some may still be actively using and attending IOP as the least restrictive level of care that they can manage instead of going to inpatient. Their severity across ASAM dimensions may be high, but the readiness to change in Dimension 4 is not. And even in OP, sometimes we see clients who are in active use, not yet taking consistent action steps. Maybe they're raising kids, holding down full-time jobs, or simply unable to commit to 9 hours a week of IOP, even though clinically, IOP might be the most appropriate fit. ASAM helps us organize what should happen, but life doesn't always fit neatly into levels of care. And this is where the real work begins. At Jade, this tension shows up often. Clients refusing IOP, clients admitted into OP while still in active use, or clients lingering in evaluation, withdrawal management without ever transitioning into groups. And I just want to make it clear because these are some of the common hiccups that we see moving from assessment into treatment. That sliding clients into 2 groups a week for IOP indefinitely is not supported by ASAM. ASAM does support during a step-down process of moving from 3 groups a week to 2 groups a week for a maximum time frame of 2 weeks. But again, that's only during transition from IOP to OP. 2 groups of IOP a week is not considered IOP. Therapists have to balance insurance justification, group culture, and medical necessity while making placement decisions. Admitting a client into OP who's drinking 20 drinks daily, that would be Dimension 1 and Dimension 5 severity, may create both clinical risk and group disruption. Some flexibility, however, is possible, like short-term behavioral contracts. So saying something like, I want you just to try IOP for 2 weeks and then we'll reassess. Or we could even consider an OP plus model with 2 groups a week plus individual sessions and peer support, but that must be framed as a time-limited clinical trial and not a permanent substitution to that client getting the level of care that they need. Every group that you lead will contain a mix. Different stages of change, different severities, different worldviews, cultures, recovery goals, and drugs of choice. Group in many ways ends up looking like the real world itself, a space full of diverse needs and competing realities. That diversity can feel overwhelming if we cling too tightly to what the group should look like. But if we accept the group as it is, we can find ways to help clients feel connected to each other, to themselves, and to their own recovery process. So I want to give a practical example about Dimension 4, or readiness to change. In IOP, that might mean using psychoeducation to help contemplative clients recognize ambivalence as a normal stage, while simultaneously supporting action stage clients in skill building. Both can be in the same room, and your job is to tailor interventions so each client feels seen. And this is where the paradoxical nature of change comes in. If we show up with rigid expectations, deciding ahead of time what every client should be doing at this stage or in this group, we risk losing them. But if we show up with presence, preferences, and flexibility, we create space for clients to surprise us. The paradox is that the less we push for change, the more likely clients are to risk trying it. And at Jade, flexibility does not mean enabling. It means clinical contracts, clear boundaries, and using ASAM dimensions to justify every decision. Sometimes some treatment is better than none, but sometimes offering less than the recommended level of care creates more harm than help. Our responsibility is to weigh those factors carefully, document the rationale, and keep the group safe while still meeting clients where they are. So yes, group is fun, but it's not easy. And it definitely won't be easy if you keep focusing on what the group should look like instead of what it actually is. The real art of group counseling is embracing the messiness, trusting the ASAM framework to guide your decisions, and walking alongside clients as they move, sometimes slowly, sometimes unevenly, toward their own version of recovery. And one of the most important truths about group counseling and addiction treatment is this. Not everyone walks into the room wanting the same thing. Some clients arrive clear that abstinence is their only path. Others want to cut back or just use more safely. Still, others are there because they're mandated or because family pressure finally outweighed their resistance. In motivational interviewing terms, this is ambivalence, and it's not a problem to be solved. It's the ground we work on. At Jade, we expect this mix. We see it every day in IOP and OP groups, and we design treatment to hold it. Our ASAM 4th edition lens reminds us that mixed motivation often reflects differences in Dimension 4, readiness to change, and Dimension 5, risk for reoccurrence, not a lack of willpower. Some clients arrive with severe withdrawal history but low readiness. Others show high motivation but unstable recovery environments. This group is where all of these intersect. Welcoming ambivalence means treating it as a normal part of recovery. When a client says, I'm not sure I'm ready to stop, instead of correcting them, we can lean in with curiosity. Well, what do you enjoy about using? What are some things you don't enjoy? That's motivational interviewing spirit, exploring both sides without judgment, knowing that ambivalence is often the doorway to change. In groups, this gets complicated because members hold different goals and worldviews. Some may feel strongly that abstinence is the only real recovery, while others are experimenting with moderation or medication-assisted treatment. Our task is to balance abstinence and harm reduction in group norms, and that means setting the tone early. This is a space where all recovery goals are respected, We may not choose the same path, but we're here to learn from each other and support each other's progress. At Jade, that balance also means being explicitly co-occurring capable. Clients might say, well, I only use because of my panic attacks, or I can't stop drinking until my depression is treated. Those statements aren't excuses, they are clinical information. They tell us to work across both tracks of recovery, substance use patterns and mental health drivers. Harm reduction in this sense is also reducing psychiatric harm, staying on antidepressants, engaging in therapy, or learning grounding skills that may be just as life-preserving as carrying naloxone. This also means supporting MAT conversations. When someone shares that they're on buprenorphine or methadone, the group leader's response matters. Rather than letting stigma take hold, we can normalize and affirm. Medications is just one of the ways that people stay alive and engaged in recovery. Let's make space for what that means for you. And at Jade, we go further. We connect those disclosures back to ASAM placement, document them in group notes, and highlight them as evidence of treatment engagement in treatment plan updates. In a harm reduction frame, we also value incremental progress. A client who moves from daily use to 3 days a week, or who starts carrying naloxone, is taking real steps towards health. In motivational interviewing language, these are change talks, small shifts in behaviors and perspectives that we want to catch, reflect, and reinforce. We also frame lapses as learning opportunities rather than failures. Instead of, I blew it, I'm back at square one, the group help reframe. What did this slip teach you about your triggers? What will you try differently next time? At Jade, we document these moments as clinical gains, not failures, because they show movement across readiness and risk dimensions. Ultimately, harm reduction in groups is about creating an inclusive culture. It's easy for group members to compare and compete, but we can redirect towards collaboration. We can take the stance as one of partnership, evocation, and compassion. We don't force readiness. We draw on what's already there, planting seeds and practicing well. So when you step into the mixed motivation group, remember your job is not to get everyone to the same destination at the same speed. It's to hold space where people can explore, compare notes, unlock new parts of their maps, and move forward in ways that they're willing and able. That's the paradox of this work. The more we let go of control, the more room clients have to grow. And at Jade, that growth includes both substance use recovery and mental health stability held together in the same room at the same time. Groups work best when people feel safe, respected, and engaged. But there are some non-negotiables and some extreme parameters, times when clients' behavior disrupts the group or threatens safety so significantly that we have to consider discharge or referral to a higher level of care. Common examples include repeated inactivity in care, clients who chronically skip groups or sit silently without participating despite support and redirection. Another is presenting under the influence in ways that disrupt the group. If someone is impaired and unable to stay safe or respect the space, we can't just ignore it. Safety for the whole group has to come first. At Jade, this process is always anchored in the ASAM criteria. If somebody is repeatedly disengaged, we look at Dimension 4, readiness to change, and Dimension 3, emotional behavioral conditions, to see whether ambivalence, untreated depression, or anxiety are driving their withdrawal. If someone shows up impaired, we assess Dimension 1, acute intoxication withdrawal, and Dimension 5, risk for reoccurrence, to determine whether stepping up to a higher level of care or even a brief withdrawal management referral is warranted. Again, the goal is not punishment. It's matching the right level of care to the actual clinical need. And here's some simple language that you can use as a facilitator when somebody shows up impaired to your group. I can see you're not in the place to fully participate today. For your safety and for the group safety, I'm going to ask you to step out. We'll follow up individually to figure out what support you need. Or you could try, I'm really glad you came today because showing up matters, but it's not safe to continue group when you're under the influence. Let's pause here and make a plan for next steps. Most agencies have rules, sometimes a 3-strike relapse policy, but harm reduction challenges us to think more flexibly. A relapse doesn't automatically mean failure or that somebody needs to be punished. Sometimes relapse is an opportunity for learning, and the group can hold that person with compassion. But if relapse turns into repeated disruption or creates risk for others, then we may need to step someone up to a higher level of care or put boundaries around their participation. And this is where clinical judgment matters most. It's not always black and white. At Jade, this judgment also includes our co-occurring lens. A client repeatedly disruptive in group may not just be resistant, they may be experiencing untreated PTSD flashbacks, manic symptoms, or severe panic attacks. Referral might not be to a higher substance use level of care, but to psychiatric stabilization, medication adjustment, or a trauma-focused track. Documenting these nuances is part of how we practice co-occurring care. One way to navigate this is to bring the group into the process. Rule setting can be collaborative. At the forming or norming stage of group, it's helpful to say, let's talk about what respect looks like in this group. What do we expect of ourselves and of each other? This helps clients take ownership and also creates buy-in when those rules need to be reinforced later. But here's the important part. Rules need to be clear and specific. Saying respect everyone isn't enough. Respect might mean putting your phone away during group, or to some, it might mean not swearing at someone, even if maybe swearing in general is okay. For me, my own guideline is this. Swearing is fine when it's about expressing yourself honestly. It can even be cathartic. I swear all the time. But derogatory language, racial slurs, or words that make somebody feel other than are not okay. For me, respect is about building connection, not tearing it down. Asking your group what respect looks like for them can be a really beautiful conversation. And creating some guidelines around whatever they come up with is a great way to start setting rules in the group. And I also want you to notice how rules are phrased. A list of no's, no running, no yelling, no texting, no cursing, tells people what's not welcome, but it doesn't guide them toward what is. Instead, we can use welcoming and connecting language, like practice active listening, or step outside if you need to take a call, or speak your truth but don't attack others. This frames rules as shared commitments and not punishments. And remember, group rules aren't fixed forever. As people move through the forming, storming, and norming stages, their expectations of self and others shift. Rules should be revisited and clarified along the way. And talking about rules is also a great way to start a conversation about boundaries. Many clients with substance use disorders and often co-occurring mental health challenges struggle with boundaries. Boundaries are the personal rules and limits that help us define what's okay and what is not okay in relationships. Some clients come in with rigid boundaries, others with porous ones. Group is a perfect place to explore what healthy boundaries look like in practice, both with self and with others. Setting group rules together is one way of practicing this skill in real time. And at Jade, we could even frame this as boundary work across ASAM Dimension 6 recovery environment of how do your boundaries protect you at home, at work, in relationships, and here at group. So while discharge and referral are sometimes necessary, they aren't the starting point. They're the last step when safety or engagement simply can't be maintained. More often, the work is about helping clients clarify expectations, define respect together, and practice boundaries in a supported, structured space. In the end, group rules aren't about control. They're about creating the kind of environment where people can take risks, be vulnerable, and move toward change. At Jade, we hold this with loving accountability. We give clients every chance to stay engaged, but we also protect the group as a whole. Discharge and referral are tools that we use sparingly and always with the intent of moving clients towards the right care at the right time, not pushing them out, but stepping them up or across so that their needs are met. Addiction groups bring unique dynamics that you won't always consider in other counseling groups. These dynamics can make the work more complicated, but they also provide opportunities for really deep healing if handled with care. So let's walk through some of the most common challenges and how to approach them. The first being trust and confidentiality. Confidentiality is the foundation of group work. HIPAA protects clients from providers disclosing their information, but it does not stop group members from talking about each other outside of session. And that's why we have to set a very clear norm. What's said here stays here. Trust also means being thoughtful about admissions. In small communities like Pittsburgh, it's almost inevitable that people will know each other through family, recovery housing, workplaces, social networks. Maybe they went to school together. And ideally, we avoid putting close friends or adversaries in the same group. But again, the world isn't perfect. When overlaps do happen, we don't ignore them. We're going to address it directly. You can say something like, it sounds like there might be a conflict of interest here. Let's talk about what needs to happen so that everybody can feel safe, whether a different group might be a better fit. Trust takes time to build, but cracks, if left unattended, can erode safety quickly. The second issue is handling relapse disclosures. Relapse is a reality in recovery, and how a group responds matters. If a member discloses relapse, the counselor sets the tone. A shaming response can drive silence. A compassionate response can create learning. You can try on some language that might sound like, thanks for being honest about your use. That takes a lot of courage. Let's explore together what happened and what support you might need. Or you could even ask the group for their input and say, hey group, how do we want to respond when one of us struggles? What would support look like here? We can encourage empathy, not judgment. Relapse isn't about starting over at zero. It's a recycling of the stages of change, often moving somebody from maintenance or action back to contemplation or preparation. And the group can frame relapse as data: what triggered it, what was learned, and what can be done differently next time. The third issue is dealing with ambivalence, denial, and resistance. Ambivalence and resistance are not barriers, they are expected parts of recovery. Clients may deny having a problem, minimize their use, or argue with the counselor. In group, this can ripple out quickly. Motivational interviewing helps us reframe resistance as information. I hear you saying you don't think your use is a problem. What are some things you enjoy about it, and what are some things that you don't? We also want peers to learn a healthy response. The goal isn't for the group to gang up, but to model curiosity. Who else has felt unsure about whether they wanted to change? What helped you sort it out? Ambivalence is contemplation. Denial is pre-contemplation. Both are doorways, not walls. By modeling patience and curiosity, the group shows that being stuck is still part of the process. So we're just going to do a little thought experiment here. So I want you to think about a recent change process in your own life. Maybe it was something small, like starting a new health routine, switching up how you handled paperwork, or following through on a new habit. Did you express disinterest at first? Maybe drag your feet towards implementation, or vent to a friend or coworker about how much you just didn't want to do it at all? Did you relapse into old habits on purpose, slip back accidentally, or even just outright refuse the change at all? Now stretch the lens a little bigger. Think about a major life decision: going back to school, changing jobs, getting married. How long were you thinking about it before you actually did it? How much ambivalence lived there before the action happened? Use that memory to remind yourself what ambivalence feels like in your own body, because that's exactly what clients are sitting in when they show up in group. Now, the fourth issue is diversity of member histories. Groups often bring people together whose backgrounds could create tension: drug dealers and clients who lost loved ones to overdose, people with co-occurring trauma, or members from vastly different cultural and socioeconomic contexts. The counselor's role is to acknowledge differences openly. You could say something like, "We all come into this room with different histories and perspectives. That diversity can make us uncomfortable, but it can also be a powerful teacher. Let's focus on what we can learn from one another." And at times, you'll need to set boundaries around harmful or triggering comments. You can say something like, "I really need us to stop here." That language could be very painful to some group members. Let's reframe what you're trying to express in a way that feels safe for everyone. And when handled with care, diversity can transform groups into a corrective emotional space, places where clients confront difference without avoidance, learn empathy, and practice tolerance. In sum, addiction groups will always surface issues of trust, relapse, ambivalence, and diversity. How we handle them as counselors and how we invite the group to respond determines whether these moments become ruptures or opportunities for growth. With consistency, compassion, and structure, these challenges can foster growth, accountability, and connection, helping clients move through the stages of change together. So maybe I haven't said it enough already or really convinced you, but running addiction groups is some of the most rewarding work that you'll ever do. But it can also be some of the hardest. When you sit in a room full of ambivalence, anger, grief, relapse, and hope, you're not just facilitating, you are absorbing. And without care, the cost can show up as burnout, boundary problems, or even countertransference. And I want to take a second to just talk about burnout, because it's not just feeling tired. It's sometimes defined as a tide of hopelessness and futility that can swamp even the most dedicated therapists. It often looks like depression, but it's tied directly to our work. Signs include dreading voicemails, or secretly celebrating client cancellations, or feeling a creeping disconnection from clients. And the danger isn't only personal, it can erode effectiveness and even compromise ethics. So what do? We're going to start with navigating storming and criticism. Groups are going to push back. Clients will criticize your style. Some will test limits or call you out, but remember, pushback is not failure, it is part of the process. You can use self-talk strategies in the heat of the moment. Tell yourself to take a breath, don't take it personally, and ask yourself what else might be going on here. Think of it as practicing what we teach, using reframing and mindfulness on ourselves. The second thing that you can do is look towards boundaries. Therapists walk a tightrope between being warm and being firm. The boundaries we set are as much to protect ourselves as our clients. Healthy boundaries aren't walls, they are guidelines that allow mutual respect and safe connection. And that means saying yes to vulnerability and humanity, but no to harmful behaviors, dual relationships, or blurred roles. And the third thing that we can do is look at countertransference and show up to supervision. It is inevitable that certain clients will stir up strong reactions: anger, Attraction, because people are sexy. Guilt, frustration. Freud called countertransference both the therapist's greatest tool and the greatest obstacle. And the difference lies in awareness. Use supervision, consultation, and your own therapy to unpack what shows up for you. It's not about never having reactions, it's about not letting them drive the bus. And the fourth is to practice some self care. You're gonna prep before group, but you're gonna hold on to those plans lightly. Throw them out the window if that's not what the group needs today. You're gonna decompress after group. Take a walk, journal for a little bit, debrief, grab a snack, breathe, lay on the floor, whatever makes you feel good. You can also use professional associations for connection and renewal. You're not on an island. Nobody expects you to do this alone. You also want to remember that you can't meet every need. You are going to make unpopular calls. Not every group member will like you. That's okay. And one way to sustain yourself is to look for glimmers, small positive cues of safety, connection, or joy. Trauma research tells us to notice triggers. Self-care asks us to notice glimmers. In group, a glimmer might be a member making eye contact for the first time, or a laugh shared between peers, or somebody saying, "This is the first place I felt understood." These moments might seem small, but they are powerful antidotes to burnout. They remind us that healing is happening even if progress feels slow. So I want you to pause here and just think about one glimmer from today. What was a small moment that made you feel connected, hopeful, or safe? And now think ahead. What glimmer could you create for yourself this week? Maybe it's a walk with a friend, or listening to a piece of music that you love, or maybe just 5 minutes of silence between sessions. Don't scroll on your phone, don't put on TikTok, just sit and breathe. And the fifth thing that I want to talk about here is group member styles as a mirror. So self-care also means learning to ride the waves of group dynamics without drowning in them. So I want you to think of the different types of group members that you encounter. There's leapers, creepers, and sleepers. Now, the leapers, they jump in early and often. They've got really great energy, but sometimes they can overshadow others. The creepers are quiet, observant, slow to engage. They might need direct invites, or they might even need you to make eye contact with them before they engage in the group. The weepers are the criers. They are deeply moved, often holding emotional weight for the group. And the sleepers are literally or figuratively checked out. Maybe they're scrolling on their phone, maybe they're staring off into space. Sometimes they're showing up intoxicated. Each style requires different responses, but I want you to notice your own reactions. That's the point here. Do you get frustrated with sleepers, or maybe you overly rely on your leapers? Maybe you try really hard to avoid the tears of the weepers. Self-awareness here is crucial. These dynamics are going to mirror family roles, trauma triggers, and also your own group identity in staff meetings, classrooms, or even family dinners. So here's the takeaway. Self-care and group work is not just bubble baths and vacations, even though both of those are lovely and you should absolutely take vacations. But self-care is actually ongoing discipline of boundaries, supervision, reflection, and compassion for your clients and for yourself. Groups will test you, but if you can stay grounded, flexible, and human, those very challenges can become your best teachers. Wrapping up today, group therapy in addiction counseling is both an art and a science. The science gives us frameworks, ASAM criteria, motivational interviewing strategies, Yalom's therapeutic factors, and the stages of group development. But the art is how we bring them to life, moment by moment, client by client, group by group. Success in groups isn't measured just by attendance. A full roster means little if members are disengaged, silent, or disconnected. Real success looks like engagement, culture, and responsiveness. It's clients leaning in, giving feedback, and taking risks. It's the group learning to hold each other accountable and to carry hope when someone can't hold it for themselves. Groups are microcosms of life. They surface ambivalence, conflict, relapse, and grief, but they can also create space for connection, catharsis, and growth. Within the group, clients practice the very skills that they'll need outside: boundaries, honesty, empathy, persistence. And that's where the counselor's role comes in. We're not here to force change or to control outcomes. Our role is to welcome resistance as part of the process, to set structure and safety, to support persistence even when progress feels small, and to build a culture where recovery in whatever form it takes is possible. If you take nothing else from this lecture, let it be this: groups are living systems. They will surprise you, frustrate you, challenge you, and teach you. But if you show up with structure, flexibility, and compassion, group therapy can be one of the most powerful healing tools we have in addiction treatment.